Anticoagulation therapy is essential in modern medical practice to prevent pathological blood clots. These clots can lead to severe conditions like deep vein thrombosis, pulmonary embolism, and stroke. Effective anticoagulation reduces morbidity and mortality. Healthcare professionals must understand these agents for safe patient management. Balancing clot prevention and bleeding is a clinical challenge. Anticoagulant medications are diverse, classified by their mechanisms of action. Major classes include vitamin K antagonists, direct oral anticoagulants, heparins, parenteral direct thrombin inhibitors, and synthetic pentasaccharides. Each class has unique properties influencing indications, dosing, and monitoring. Vitamin K antagonists like Warfarin inhibit vitamin K epoxide reductase, affecting clotting factors. Warfarin requires regular monitoring using the International Normalized Ratio. Direct oral anticoagulants, including factor XA inhibitors and direct thrombin inhibitors, have predictable pharmacokinetics and ease of use. Examples include rivaroxaban, apixaban, edoxaban, and dabigatran. DOACs generally do not require routine laboratory monitoring. Heparins, including unfractionated and low molecular weight heparins, potentiate antithrombin 3. Unfractionated heparin requires monitoring with activated partial thromboplastin time. Low molecular weight heparins have a more predictable response, often not requiring routine monitoring. Synthetic pentasaccharides like fondaparinux selectively inhibit factor XA. Understanding these classifications allows clinicians to tailor therapy to individual patient needs. This ensures efficacy in preventing clots and safety in minimizing adverse effects. A clear grasp of these differences is fundamental for appropriate drug selection and management. Anticoagulants prevent and treat thromboembolic disorders. Atrial fibrillation significantly increases stroke risk, and anticoagulation is crucial for prevention. Venous thromboembolism, including deep vein thrombosis and pulmonary embolism, is another major indication. Anticoagulants prevent further clot extension and embolization. Initial treatment often involves parenteral anticoagulants followed by oral anticoagulants for long-term prevention. Post-operative thromboprophylaxis is critical, especially in orthopedic surgeries. Pharmacological prophylaxis reduces the incidence of post-operative deep vein thrombosis and pulmonary embolism. Patients with mechanical heart valves require lifelong anticoagulation, typically managed with warfarin. Other indications include certain acute coronary syndromes and hypercoagulable states. The decision to initiate anticoagulation involves assessing benefits versus bleeding risks. This assessment must be individualized for each patient. Effective anticoagulation therapy improves patient outcomes and reduces healthcare burdens. Effective anticoagulation therapy often requires careful laboratory monitoring. This is particularly true for warfarin and unfractionated heparin. Monitoring ensures the anticoagulant effect is within the therapeutic range, minimizing risks of thrombosis and bleeding. For warfarin, the International Normalized Ratio, INR, is the standard monitoring test. The target INR range typically falls between 2.0 and 3.0 for most indications. Monitoring frequency varies, being more frequent during therapy initiation. Unfractionated heparin is monitored using activated partial thromboplastin time, APTT. Low molecular weight heparins generally do not require routine monitoring. Direct oral anticoagulants, DOACs, do not require routine laboratory monitoring. In certain situations, such as suspected overdose or urgent surgery, measuring DOAC levels might be considered. Specific quantitative assays for dabigatran and anti-factor XA inhibitors are available. The lack of routine monitoring for DOACs simplifies therapy but emphasizes adherence. Effective monitoring strategies ensure safe and effective anticoagulation therapy. Bleeding is a significant concern with anticoagulant therapies. Management depends on severity, location, and the specific anticoagulant involved. Initial steps include discontinuing the anticoagulant and supportive measures. For minor bleeding, withholding a dose may suffice. For major bleeding, aggressive interventions and specific reversal agents are required. Warfarin-associated bleeding can be reversed with vitamin K or prothrombin complex concentrates. Idarucizumab reverses dabigatran, and andexanet alpha reverses factor XA inhibitors. Non-specific hemostatic agents may be considered when specific reversal agents are unavailable. Managing bleeding requires understanding the anticoagulant used and available reversal strategies. The advent of direct oral anticoagulants, DOACs, has altered anticoagulation therapy. DOACs have a rapid onset, shorter half-life, and fewer interactions compared to warfarin. They offer predictable effects and fixed dosing without routine monitoring. Clinical trials show DOACs are as effective as warfarin with a lower risk of certain bleeding types. The choice between DOACs and warfarin depends on patient-specific factors. Renal function, valvular heart disease, adherence, cost, and availability of reversal agents are considerations. Clinical judgment is crucial in selecting and managing anticoagulant therapy. Guidelines from organizations like the American Heart Association provide valuable direction. Continuous learning and staying updated with new data ensure optimal anticoagulation care. Tailoring therapy to individual needs improves patient outcomes and safety.